question about anyone you're asking about. If you wish to receive CMEs or CEUs for today, you will be asked to either chat your attendance or unmute your phone and tell us in person. We might ask you to answer questions. Jeannie might ask you, because she knows you all. You are able to say pass if you don't want to answer the question, but we do want to hear from folks in the audience who have expertise. So if you look at your screen now, you should have an icon for a video. You can start and stop the video, and you can mute and unmute so that we can hear you. You can be doing this is all within the Zoom software. Here is a disclosure and accreditation statement. For case consultations, which we have coming up next week, those of you who have Molina or Blue Cross Blue Shield patients, there is reimbursement available for your follow-up visits, so contact Michelle or Kevin for any more information on how to get reimbursement. For those of you who would like to view this at a later date or share this with your colleagues, we do have an online training course on our website, which is a Moodle platform. And here are the steps, but also contact Michelle Widener if you have questions about how to do that. This is your opportunity to tell us who you are and where you practice. I see a couple of folks have already chatted this morning. We would like to hear your lovely voice this morning, so please unmute your lines. And Jeannie, did you go over in terms of questioning whether we want questions at the end or in the middle?
Yes, yes. So I'll get to that.
All right, so I'm going to turn it over to Jeannie Dalen, your host today, to introduce our speaker.
Good morning, everyone. Welcome again to Adolescent Health Initiative on this beautiful Wednesday morning. I see that everyone is chatting, Robin and Blanca and Sherry and Tilly, so thank you for chatting in. Is there anyone who'd like to announce their name over the speaker, just to make sure that you guys get credit for your CMEs for today? Okay, so just remember to continue, just to be sure by the end of the lecture today that you go ahead and let us know that you're here, so you're able to get credit. We have a wonderful presentation topic for this morning, and there's a lot of great information. So what we'll do first of all is we'll go ahead and go around the room and announce, let you guys know who's here joining us in Envision Studios, and then we'll get started today.
My name is Maya Trio. I'm a quality improvement specialist with Envision New Mexico. I'm Amanda Scotch-DeFull. I'm a dietetic intern and a graduate student in nutrition working with Dr. Bennett.
I'm Carrie Jones. I'm also a dietetic intern working with Dr. Bennett.
I'm Daria Anderson, QI specialist here at Envision.
And this is Kirsten Bennett again, now playing the role as pediatric dietitian.
And with that, we'll turn it over to our presenter for today.
Hi, everybody. Thank you for coming. My name is Sean Sidhu. I'm an assistant professor at UNM, the Department of Psychiatry. I'm the associate training director for the General Psychiatry Residency Program. And I work on a number of kind of like health systems-based research projects throughout the state. So that would be like Native American school-based healthcare, suicide prevention, trying to get our trainees placed in rural areas. So access to care issues, those are the things I'm passionate about. Today's topic is psychotropic medications in the classroom, although it doesn't necessarily have to be in the classroom. It could be really for any adolescents. And I sort of felt like rather than bombard you with all the details of psychopharm, which can be really nitty-gritty, and we could read textbook after textbook about psychopharm, maybe it made sense to go over the approach that I use in talking to families about, and teachers and folks that we're working with about, like medications in general, what kind of questions parents might have for you. And then in the end, we'll move towards some of the content. And then I think even then it's more important to get the general concepts than it is, well, each specific medication has these side effects and these indications. I mean, you could probably look all that stuff up anyways. So we'll get started here. So definitely this is meant to be more of a discussion, and we've been able to pull up the chat window, so I can even see the comments that you're writing, which is awesome. Thank you for that. So please feel free to chime in with thoughts and questions and comments along the way, because I'll be asking you a lot of open-ended questions as well. So I don't think that this has any sort of an impact on today's discussion, but I write continuing medical education questions for the American Psychiatric Association, and we receive a small royalty for that. So I'm in the habit of putting everything down just in case, but I don't think there's a conflict with that today. So today we're gonna be able to identify students who might need meds. Maybe after today, you might be able to say, I might go with this treatment over that treatment. And then the third, this is kind of like inverse, we'll talk about number 3 first, is really around the communication with medications and things of that nature. So first open-ended question of many is, when might you urgently consult a mental health provider? So it sounds like some of you are working in primary care settings. I think there was somebody signed up from the school-based health center. So in general, like, when might you consult somebody like me? I realize this is a super open-ended question.
So please feel free to unmute or type questions in the chat box. For Sean, I can say, as people are starting to formulate their answer to that, one of the biggest things that I find is when I do just depression screens, and what comes up is a worry about suicide ideation or major depression. That's when my role as a psychologist, I almost feel like I need more assistance that is outside the realm of my expertise, and maybe even a higher level mental health provider for myself. Sandra is typing in psychotic symptoms. Absolutely, Sandra.
Yeah, I think those are great. Those are great answers. Those are things that would come to mind for me. Any other thoughts about that from folks in the room before I move on? Okay, I usually wait a good 30 seconds. Yeah. So I would say, depending on what's going on, one thing that might cue you in is a change in functioning. And that might be like a teacher or a parent who might notice that, but not specifically notice psychotic symptoms. Maybe they don't know what psychotic symptoms are, the people who are observing these changes. And then, so because this talk is about school, concerns over safety at home, a lot of times teachers might be the first folks to notice changes in a kid, or the kid will be writing something about, like, a story where the character gets abused, or drawing a picture where, something sort of says to the teacher, there might be something going on here. They might see marks on the kid or whatever. And this one was already, that's why I like doing these discussions, because you do my work for me. But then also, a lot of times people will mention things with the open-ended questions that I didn't think to mention. So yeah, naturally, if a student makes suicidal or homicidal statements, and then again, so looks like our little panel here was right on. And so the next question, open-ended question, is, the first question was, when would you consult somebody like me? Okay, and the second question, let's say there's a family that's working with you and they're asking you, do you think my kid needs meds? When are medications necessary? How might you answer that question, other than saying, go see Sean over there? How might you answer that question?
I have a question while people are typing. When a student potentially is trying to self-medicate, would that be a time that you would ask? Yeah, come on. Like I'm alcohol or marijuana or any other,
yeah.
Those are obvious choices, but there's another choice out there, even tobacco, I would think.
Yeah,
to some extent.
Totally, yeah. Yeah, and that might even go, even if before we zoomed in here, even just when to consult somebody like me might be something like that too. Don't all type in at once. You're gonna jam our server.
It's early morning.
Okay, safety and function are compromised. Therapy has not been effective. Very good answer. So I'll move forward now. Okay, so basically, like, functioning is one of the main, and we mentioned in the last slide change in functioning, but the ability to function is a main sort of indicator for us. So if a kid has ADHD, but they're like getting A's and B's in school, they're not having to, you know, spend hours and hours reading the same page over and over again to get those grades at home. They're not getting Saturday schools for, you know, impulsive behavior. You might say, well, you know, we'll try classroom interventions and whatnot before we move on to medication. So yeah, okay, so how would we, here's another question for you. How would we define inability to function? I kind of just brought up one, but any other things that come to mind, what the kid might present with?
Well, I tend to think, as again, people are typing or thinking, functioning being in various domains of living, so school, home, peers. So that's really what I look at to see if any of those there's a difficulty or there's great dysfunction that's causing them to say distress. That Sandra mentioned that when therapy just is not effective, they are not even in a place that they can use the tools to be able to get to a level of functioning.
Yeah, there's really like no wrong answers. So feel free to chime in. This isn't like there's a specific, there's such open-ended questions. And I think basically you just hit the nail on the head. So I had mentioned sort of cognitive functioning or academic functioning, but there's also social functioning. A kid could do really well academically, but really struggle with peers. And so it could be classroom disruption. If you have older adolescents, it could be disruption in other sorts of ways as well, like maybe on the sports team, for example, or extracurriculars, or other types of disruptive behavior. This could also be like, you know, just leaving home and sort of running away and not listening to parents and stuff.
So Sean, there's also Violetta had a comment that
oh, great.
Not eating, sleeping, going to school or working, so not doing any of those, or trouble in relationships.
So I think this is a perfect example of why we have people write in, because I didn't actually think to include on this slide the biological components of eating and sleeping, which are great points, and absolutely. And especially with the, you know, social media, texting, you know, kids are not sleeping at all, especially the older kids. Yeah, and then if there are concerns from adults about the kid's emotional and mental well-being, which is again a pretty vague statement. So I think it's unfair to ask you an open-ended question that's this broad. So I'll just kind of like say what I think my core ethical dilemma is when I approach the topic of prescribing medications with patients and with families. It's, you know, what do I think is good for them, and how do I respect their wishes, which is the same thing as beneficence versus autonomy. So, and then autonomy could be the kid, it could also be the parent. And there's tremendous variation in state laws. So in California, which is where I lived before I came here, up to 18, kids were not able to consent for their own medications, and parents could sort of force kids to take medicines up to 18. In New Mexico, it's 14, which is a huge difference. So a 14-year-old in New Mexico can sign for their own meds, sort of like with birth control. And even if their parents sort of don't want them to be on the meds, or if their parents aren't aware of them being on the meds, they can do it anyways. We always try to bring the parents in just because it's better. But legally, a 14-year-old here can sign for their own mental health treatment and care. And so, and here at 14, if a kid says, no, I don't want to be on the medicine, the parents say you have to take it, then it has to go to court. And you have to have an independent judge who arbitrates the case. And some of it, I mean, quite often they'll find in favor of the kid if there's not a great justification. So that's the main ethical dilemma that I think we usually face with meds. I mean, there might be other ones that I'm missing out on. So if you were gonna, this is again a very open-ended question, But if you were going to sit down and talk with parents, what might be one of the first few things that you would talk about with them with regard to medications? If you say, let's say you kid Johnny, you think Johnny needs medications, you're sitting down with Johnny and the parents, what would you say, how might you start that conversation off with the parents? And I've learned this the hard way by starting a lot of these conversations off the way that you wouldn't want to.
So not to go back to, because this is, as people are thinking about the discussion with parents, Felicia has a question. Is it true, though, that the healthcare provider has to inform the parents when initiating a psychotropic med on their child?
If less than 14, it's legal. If over 14, it's considered a professional courtesy and it's encouraged. So like we have an inpatient hospital at UNM for kids. When we start medicines on kids over 14, we'll always try to notify the parents, and we'll document that we try to notify the parents, but legally we can actually start it before getting their permission. I wouldn't recommend it because that's a good way to break trust with the family instead of sort of encourage trust. But there are some situations where, let's say the kid is saying, I'm really suicidal, and the parent says they're not depressed at all, and the kid's like, I just tried to kill myself, and you're worried. And then in those situations, you might actually prescribe it, and just you would then document why. It looks like there might be another question.
Yeah, this is a good topic. So Felicia did say got it. I was always under the impression that informing them was a legal obligation, even probably over age 14.
Yeah, and I noticed somebody signed in from Portland. I have no idea what the Oregon laws are around that, so it'd be good to check.
Yeah, absolutely. Lisa has a question. Does that also mean that they can stop taking medications such as ADHD medications that the child does not want to take, so
Yeah.
vice versa?
Let me make sure I understand the question correctly. Is it asking if the kid can stop the medication on their own?
I believe so.
And the answer to that is yes.
Yes.
The kid can stop the medication on their own. And if the parent says you have to take it and the kid says no, then that has to go to court. We have a mental health court as part of our mental health center at UNM, but I haven't tried to arbitrate one of these processes in like a rural community. So I'm actually not sure how that would go. I'm not sure which court you would go to for that. But you would need some sort of a legal sort of outcome for that. Yeah, maybe it would be family court. I'm not sure. It's a good question for myself. Okay, so I want to make sure we keep moving because there's a bunch of general questions, and we have 10 minutes before I said we'd move to the content. So discussion with parents. Any sense of how you would start out this topic?
As people are typing, this is one of the trickiest conversations to have, I think, especially the starting. And so what I typically try to do is talk about having many treatment options and that we're trying to find the best fit. And so I usually try to make it more broad-based in terms of that we're going to be considering all options. And so it's not just about medication, it's not just about therapy, but typically a combination of both can be very helpful. But sometimes I feel like that opens more of a can of worms than so I actually would love to hear people's advice or what others have done in starting a discussion with parents as well. They probably feel the same way.
Yeah, I think I usually count to 15 in my head. So I'll move on. I'll tell you a story about how I learned this the hard way. So it says, first get the family's opinion on how the child is doing and what they think would make things better. And so I had a patient that was in the hospital, and I sat down to have this discussion with parents, and there was a parent that became pretty agitated and angry, and I was wondering, like, am I going to need to call security here? And, you know, I was sort of trying to express my view as the doctor, like the one with all the knowledge. And, you know, it was just like I was meeting resistance. And so I just kept pushing harder, because that makes sense, right? And so then it ended up where we just kept butting heads, and like, you know, and then I had a social worker with me at the same time, and the social worker was really experienced. He's actually someone I respect greatly, very good friend. And he said, let me ask you a question to the parent. He said, what's your experience around psychotropic medications? What are your thoughts about psychotropic medications? Sounds like a no-brainer. You probably should start out with that, right? But I didn't in this case. I was busy, like, you know, and I think sometimes when we're rushed, we don't do what we're always supposed to do. And the guy was like, he's like this big guy. He's got, you know, teardrop tattoos, pretty menacing looking guy. And he starts crying. And he starts talking about when he was a kid, he had ADHD, and he felt like a guinea pig. And he talked about all the side effects he had and how the real problem was at home, and nobody was addressing the real problem, and they were just throwing meds at him. And then it was like, bing, light bulb.
Motivational interviewing 101.
Right. So that was like the first year I was working after training. And so that was my lesson for, okay, first let me find out what the family's experience has been with this stuff before jumping into a conversation too quickly. So yeah, I would first just say, like, what do you think? I would ask them what they think is going on with the kid. I would also ask them what their experience is in mental health. And like, as was already mentioned, I would start out asking what could be done that's not medication oriented. This could be home stuff, it could be classroom stuff, it could be social stuff. Okay, so just showed you the first answer, but if you guys were to brainstorm, what, like, let's say a kid's coming in, I don't know, let's say they have ADHD, just for example. Let's say they have ADHD and you're worried about depression. What non-medical solutions could we brainstorm, let's say in a classroom setting or at home?
You can answer, Jane.
Okay.
Like if there's a teacher, the teacher's asking you, what can I do with this kid in this particular situation to help them be as successful as possible?
So Sandra says, altering the environment to encourage success. Mm-hmm. We could ask if they had been taught any self-regulation skills.
Yeah, great.
Great one, yeah. Both are great.
I'm guessing that a lot of you who are tuning in for this do a lot of this sort of thing on a regular basis.
Yeah, we have a lot of school providers
Yeah.
that work in school-based health.
So what do you guys do when when the teachers call you into their classroom and ask for help? Minimizing distractions, that's a great one.
So I wonder too if the discussion with the teachers, you know, that by the time a teacher calls for help, they've probably tried a few things already in the classroom. So the teacher is extremely frustrated at that point. So I wonder what the role of you all as providers in sort of de-escalating the school response to a child that at that moment in time has pushed all the available buttons. I mean,
yeah, that's a great point.
So you talked about parents, but you know, how do you?
Good point, right.
And the teachers, they may have tried a bunch of things, but they might not have the time or the resources to do it in as thorough of a way as somebody whose job it is to come into the classroom and do those sorts of interventions. Looks like a lot of discussion about physical activity and movement. I actually heard of some schools using those like bouncy balls that people sit on for ADHD kids. Okay, I think we have a pretty good list to move on. So they're like behavioral classroom interventions, the ABC, the antecedent, behavior, consequence. when kids do things, why do they do them? What's their motivation for the behavior? Can you set up a rewards program to encourage the student to have the behaviors that you want? There are school counselors, which I think sometimes are for emotional issues for kids, other times they're for like behavioral. There are all the other things in an IEP, so physical therapy, occupational therapy, academic skills training, speech and language, social skills training. For some kids, one-to-one aids are required. Those are typically if they have severe behaviors or developmentally disabled kids. Okay, so if a parent asks you, what do you think about therapy? Let's say the parent is coming in, they say, we want our kids on medication, and that's the primary thing. And then you say, you know, is a kid in therapy? They say no. Then they say, what do you think about therapy? Why should the kid be in therapy? What would your response to that be? With you guys being therapists, I guess it might be easier to answer this question.
Well, I think using those same motivational interviewing skills that you talked about, the flip side, it really goes the same for this as well, is when you typically ask what the experiences have been about therapy in the past, that's always a great way to start. You can get a lot of information about what people think about it, what they know about therapy, even just what they know, even if they have no past experience. And then I'll usually what I'll do is kind of like the ask, tell, ask, where I'll ask them, it's okay if I share with you what's available now, like, you know, kind of talk a little bit about evidence-based treatments and what's available today. And just as a support that, again, I typically talk about broad treatment plans, that if we think of it in a broad-based way, that there's many little things that we can do to add up to a big thing.
It depends on like what the kid is presenting for. This is a very broad topic. And so your conversation with the parent that has a child who's developmentally disabled is very different than a kid who has depression, which also varies from mild to severe to ADHD. So it depends. But I mean, I usually say to parents, just to kind of disarm them about the whole medication thing, that, and I genuinely believe that a lot of the long-lasting changes kids make are through therapy, through learning life skills, through having changes in perspective. And I really view medication as helping them to get through a rough spot, helping them to get sort of unstuck if they're kind of stuck in a certain pattern, or if a kid has just had sort of like trauma after trauma after trauma, and they can't escape it. Sometimes it can help with the therapy also. And I'll usually say to parents, you know, depending on, which is getting to another question actually, but depending on the condition, if it's depression, you know, we might just do a 3 to 6 month trial and see how that goes. And I think for most parents who have doubts about medications, knowing that the provider is thinking about therapy as well sometimes makes them feel better, like, okay, we're not just throwing meds at it, the situation. There are some cases where therapy is better than meds or as good. Yeah.
Yeah, I'm sorry. I was gonna. Violetta has a comment as well.
Oh, sure. Yeah.
That she encourages it as a way to offer an outlet for the child to be able to share their feelings, develop some coping skills and distress tolerance skills, as well as have a resource available to them in the school if school-based, like a school-based health center is available.
That's awesome. Yeah. I mean, a kid, if I'm seeing a kid who has performance anxiety and they're taking a test, and I've given them a medication and they're having a panic attack during a test, and they're testing that week, so they're gonna be testing every day or whatever. I mean, they have another appointment with me in 3 months. Having that person able to, like, you know, walk them through a coping skill in the moment is priceless. Yeah, and then there are some things like anxiety, for example, where I feel like the exposure therapy is sometimes just as good as the meds. Again, it depends on the condition. This is really broad conversation. And combining therapy with meds can be good. Okay, so I think we need to skip through the next part so you guys can get to the meds. But when parents ask me, do medications even work? ugh, you know, I don't know. I'm just the doctor. What would I know? So there's a few like objective kind of rating systems out there where they'll give grades to a class of medications for a disorder. You can cite that. Or like if something has the support of a meta-analysis, which is like, you know, which usually incorporates lots and lots of studies. So you're not just looking at a single study. That usually means it has more support. But I'll also say to parents, I mean, it could very well be that your kid doesn't respond to it, or that we have to try different ones. So yeah, this is just talking about how there's a kind of a grade given to each class. If you're going with something that's like off-label, you might not have as much evidence behind it. And but I would encourage parents to ask the doctor about this, because you know, some practitioners use medications that have less evidence, and sometimes there's not necessarily a good justification for that. And so when a parent asks, it might force the doctor to have that conversation with them. Yeah, so. And then how long will my child need to take medications? It depends on the condition. So we talked about, so ADHD, if you're talking to parents of a child with ADHD, what we know about that is the prefrontal cortex fully myelinates around 25. So you may see pretty big fluctuations before 25 in the course of ADHD. Kids can look really hyperactive and inattentive and impulsive, and then they can look a lot better. Usually when you get to the mid-20s, that's what you'll kind of have for the rest of your life. And so when parents say, will my kid have to take Adderall forever? Usually my answer to that is, we'll know in 20 years. But you know, it gives them a sense of what's going on in the brain. Like there's a certain part that's just not mature yet, and it will fully mature by the mid-20s. So it may be that they need to take medications forever. It may be that let's just get them through the school year and then reassess in the fall, kind of thing. Sometimes if the kid's doing better academically, we'll pull back on the dose. A lot of kids don't take ADHD meds on the weekends or over the summer, over holidays. And then for depression, anxiety, if somebody has a major depressive episode, what they've shown is that if you take the medicine for 6 months, your risk of remission is only 33%. If you take it for less than 6 months to a year, your risk of relapse is like 67%. So it's sort of it prevents further depressive episodes to take it for a little bit longer, but it doesn't mean that you have to be on it for like 5 or 10 years. And then there are some conditions like schizophrenia or real bipolar, which is different than mood swings, or autism, where, you know, depending on they may require lifetime medications, because getting off the medications might be that dangerous. So, you know, there are some situations where that occurs. So in kids, we pick the lowest possible dose. I usually go with half of the lowest possible dose, even if it doesn't work, just to make sure there's no side effects. Because if the second there's side effects, that's a therapeutic trust killer. And avoid polypharmacy. So like I'm getting some kids with 6, 7, 8 medications. At that point, you're not even sure, like, am I seeing just side effects to the medicines? Are those the symptoms? Is this the actual kid? Where does one thing stop and one thing start and stop? And if the parents say, oh, well, he's fine now or she's fine now, so I don't want to mess with it, you know, you don't really even know what's doing what. So over years, you can get meds carrying over and it just adds up. And same thing with diagnoses, those can sort of add up too. I won't take too much time going through this slide, but this slide is really getting at that if you mix certain psych meds with certain street drugs, you can get sort of bad reactions. Yeah, go ahead.
Sean, there's a comment that I just wanted to make sure that we got to. So I think this is a good point. I feel like the client teen also will have these questions about how long will I need to take them? Is this good? And these are important conversations to have with a client. They often worry significantly about the stigma of being on medication. And I've seen a lot of ambivalence with taking meds due to beliefs about how they will be labeled by friends or family if on meds.
Absolutely. If there's one thing I've learned in my years of practice that I didn't appreciate earlier on, other than listen to people, which is probably a good lesson, is that family therapy is where I get the most mileage of all. If I look at all of my modalities, including meds, I usually see the most changes in a kid through family work. I can give the kids as many meds as I want. If there's a really, really bad divorce at home and domestic violence and abuse, no med is going to really fix that. So I think the way that and I didn't mention this in the slides, it's a great point. The way that you bring this up is less of this is a problem with the kid, and more of this is a systemic problem in the family, and all families have this. All families have things to work on. Nobody has perfect communication. I try to normalize it by saying, my family is probably just as messed up, if not more. And we kind of laugh about it. And I think spreading the responsibility of the kids' symptoms to the whole family makes the kid feel less like, oh, my family's just saying I'm messed up and they're normal and I'm the identified patient and they're totally fine. And so it's just, I got to take a pill for everybody else. It's more like, well, we want the kid to take ownership of their issues, but what's going on in the rest of the family when this happens? So I think those are the best treatment scenarios usually when the whole family gets on board. And I think there are ways to do it where you can make the parents feel a little bit disarmed about it. You're not blaming them either, but just working together on it. So that's a good point, very good point. And even then, some kids don't want to take it because they feel like, why should I have to take a pill? So then you go back to your other options and you do the parent management training, or you do the family therapy, or you do different types of counseling. And then you say, okay, Susie, if you don't want to take the medications now, when will you take the medications? How bad does it have to get? So the kid can commit, like, if I get suicidal, I'll take them. Or if I get aggressive, I'll take them. Or if my grades drop for another semester, I'll take them. And then we kind of can hold them to that too. So if we enlist them in the decision-making process. Great point. So the diagnosis is super important. And input from everybody is very important in getting a diagnosis. So if you all are working with a doc, those of you chiming in, and you have opinions, please, please, please share them with the doc. Because you may be seeing something that the doctor isn't. The doctor sees someone for 60 minutes, does a new eval, and makes a diagnosis. There can be all sorts of stuff that's missed. Either the people don't bring it up, or the doctor doesn't ask about it, so it's important for us to have information from you so that our diagnosis is right, because without the diagnosis, the meds are going to be wrong. Like, I'll give you an example. I do telehealth to a clinic in Wisconsin. This is a Native American clinic, and I'm not exaggerating here. I'm probably seeing 50 to 75% of the kids and the adults there from the previous provider being diagnosed with bipolar disorder. And we know that the incidence should be like really low in kids, maybe 1 to 10%, at most 20% in adults, but that's still really high. And so there's a lot of, I've only found one true case of bipolar and doing thorough assessments so far. And so, like, all these patients that I've found are taking medications that are really toxic for no reason. So diagnosis is really important. And it decreases trust with the parents and with the kids if you give the wrong diagnosis. Okay, so now we're going to move on to the second portion. Only 10 minutes late. So one of the objectives was learn how to identify kids with these conditions. So what do you all think depression might look like? It could be in a classroom. If you see the kids in a clinic, it could be in your clinic, wherever you interface with adolescents. what might depression look like? Some of this is pretty basic stuff. Some might be more tricky.
Low affect.
Okay. Low affect.
Irritability.
Irritability.
Isolation.
Uh-huh.
They say they're bored.
Yeah.
Fatigue. Acting out, sleeping a lot, unable to concentrate, self-harm.
Great.
Withdrawn, changes in dressing, yeah.
Okay.
Anger, not
All
hanging
right.
out with friends.
We asked the right question here.
Grades dropping, not completing assignments, substance abuse, yeah. Drop in academic performance.
So, and how
Great,
many of these
guys.
things, if you think about it, if you're a teacher, how many of these things are going to be on your radar? I mean, like the acting out, the substance abuse, but some of the things that you all mentioned are pretty, like they're kind of like internalizing symptoms in the sense that if I'm managing 30 kids in a classroom, more of my attention is probably going to go to the disruptive ones. So the quiet kid, kind of a little more isolative, maybe putting their head down. I might worry about it, but I might also just be trying to get my lesson in. So for teachers, it can be hard, and these kids can get missed. But some kids might say they're sad. You might notice morbid themes. That comes up more often. So the teacher might not necessarily notice the kids more isolated or withdrawn, but they might say, "I've noticed some kind of a change in the themes in their classwork." So people had mentioned head down or isolated. Fatigue was mentioned. Interest and motivation. Yeah, naturally, if you see the kid wearing a wool sweater when it's 100 degrees outside, you might start to kind of wonder, is there something going on there? Yeah, suicidal thoughts, behavior. So the first multiple choice question. My sense is you can type the answer in. So what is the initial treatment of choice for depression? The answer choices are mood stabilizers, atypical antipsychotics, SNRIs, SSRIs, and benzodiazepines.
We got one for D.
One for D. So far 100% of the people are reporting D.
D.
Okay.
D.
All right. Bingo.
Good job, guys.
So SSRIs are the most commonly used. So those would be things on the bottom of the screen, like you hear about on TV probably, or see on, in movies. Lexapro, Celexa, Zoloft, Prozac, Paxil. They're pretty safe. They're not totally safe though. And the idea is that they have less side effects, and the SSRI, the selective part, they more selectively target serotonin. So the older medications, which you'll see MAOIs, monoamine oxidases, and tricyclics, TCAs, they're not that specific. So yes, they increase serotonin, but they also increase norepinephrine, and they also hit a lot of other stuff. So they'll hit sort of like receptors that make you tired. There are more cardiac side effects with those two medication classes. Like for TCAs, you have to get EKGs and stuff. So antidepressants, the SSRIs are pretty safe.
So, Sean, I have a question for the SSRIs. Knowing that there's different medications in that category, how do you pick which one of that category? Is it just each doctor's preference, or
within the SSRIs?
Within each class, yes.
Yeah. So some of it depends on like what your patient's insurance is and what formulary you're using. So if I'm like, for some of the Indian Health Services sites that I work with, they might have like Prozac and Zoloft on formulary, and then like Lexapro or Celexa, which are Lexapro is the most selective, and Celexa is like 1A. They're both pretty much the most selective medicines we have as far as they really just hit the serotonin. Those ones are non-formulary, so I might have to try Zoloft or Prozac first before the pharmacy will okay me trying Lexapro or Celexa. Or I'll have a patient that has something that makes me concerned, like they're on a bunch of other medicines, and so Lexapro and Celexa are less likely to cause drug-drug interactions.
Okay.
Or like Zoloft causes more GI side effects. So if I have someone coming in with anxiety and the kid like is always having tummy aches, I might say, well, that might be justification to not use Zoloft. Generally speaking, Zoloft has a little bit more evidence for anxiety, and Prozac has a little bit more evidence for depression. And Prozac is slightly more activating, so it might give people energy. Zoloft is slightly more sedating. So, and then Zoloft, people will sometimes say, like, I'm not depressed anymore, but I don't feel anything. So if you get too high on the Zoloft, you might get like an emotional zombie robotic kind of effect. So, but the bottom line is, I've seen the opposite of everything I just said.
Really?
So I've seen people who get activated on Zoloft. I've seen people who get sleepy on Prozac. You see it all.
Okay.
So I mean, you just, and to some extent, you sort of have to see how they do on it.
Okay.
There are other medications. So like Effexor and Cymbalta are more potent than the SSRIs because they include norepinephrine in their reuptake. Cymbalta has an indication for chronic pain. That's not usually an issue with kids, but for adults with like fibromyalgia. Wellbutrin has some evidence in ADHD. So if I have a kid who has sort of like a mild to moderate depression and really significant academic problems, I might start with Wellbutrin. And then Remeron is a medication that helps with sleep and appetite. Just for the sake of time, we have 10 minutes. Usually I'll ask people what they think the most common side effects are, but I kind of want to make sure we get to everything. But the most common side effects for antidepressants are not life-threatening. It might be that for the first few days when they started, their stomach might feel upset, and it might have headaches. It might feel like it makes them sleepy, or some people report it makes them like have insomnia, or that there's not as much sexual desire. That's usually when you're working with parents of adolescents, like they like that one, you know. As long as we reassure them, which we do, that it's not like it causes like hormonal or actual like structural damage to reproduction. It's just an issue of desire, like neurologically. There's a few really rare, I've seen one case of serotonin syndrome in thousands of patients at this point, and that case was when the person used a street drug with it. So serotonin syndrome is something happens when you have too much serotonin in your body, and so if you combine like an antidepressant like the SSRI with an MAOI, for example, or with the TCA, it's more likely you'll get serotonin syndrome. Or if you use an antidepressant with another, like some antibiotics weirdly increase serotonin. So what will happen is the person will get stiff, rigid, they'll get fevers, and they'll have to be admitted to the hospital. They get breakdown of their muscle, and they can even get kidney damage. So it could be life-threatening, but it's really rare. Slightly more common than serotonin syndrome, which I guess I would say I see maybe 1 to 5% of the kids and or adults will get, like, paradoxically more suicidal ideation when they take an antidepressant. I've usually seen this as a really quick thing. So in my mind, it's almost like an allergic reaction, where they take the medicine and then within the first 3 days, 4 days, maybe up to at most a couple weeks, they would get almost like restless, apathetic, and feel kind of like crawling out of their skin kind of symptoms. And in that context, will feel like suicidal ideation. Or if they really had bad suicidal ideation, they didn't tell us about it, and then the medicine gives them more energy and give them more energy to plan. But the incidence is pretty rare. If you look at like longitudinal data, the black box warning about suicidal ideation for these medicines came out like in the mid-90s, and so prescriptions for antidepressants went down, and like parallel to that was an increase in suicide in teens. And so and then people started prescribing antidepressants more, and then suicide rates came down. So the take home from that is, if we don't treat depression, there's much more suicide than these 1 to 5% of people who get suicidal ideation from the medications. But it's you got to talk to the family about that just so that they know. I usually tell them, call me right away, you know, and we'll have to hospitalize the kid maybe, just so that they're aware. So then there are a lot of unique side effects. I don't think you need to know about these unless you're a provider. Don't give Wellbutrin if there's seizures. I mean, I think we got to probably move on here. So the next question I have open-ended is, how might anxiety look in the classroom? You all were jumping over depression.
Sometimes I'll see restlessness.
I think if depression's hard to pick up, anxiety might even be harder.
Yeah.
So lack of focus, the kid could just be spacey.
Explosive behavior without obvious triggers.
Yeah, absolutely. In those cases, you'll probably notice it more. So we should probably just move on to make sure we're keeping track with time.
Unable to
jittery,
focus, upset by little things.
So a lot of these kids are behaviorally inhibited, BI, from childhood. So they would be, as opposed to the kids, ADHD kids who jump into things, they might be sort of more timid. You might see kids sweating. You might see kids panicking. You might see them crawling under their desk, difficulty separating from parents. Maybe the kid has to keep doing and redoing their homework if they have OCD. And it's easy to miss them when they're internalizing. Okay, which of the following would be the best initial treatment of choice for anxiety? And the options are Zoloft, Buspar, Klonopin, Xanax, Seroquel. Okay, we've got 1A. I'm really mindful of the time, so I just want to keep moving. And you're right, it is A. So the good news is the same thing you use to treat right now depression is the same thing you use to treat anxiety. Then the trainees will ask me, why is diagnosis so important? Because some of them are like, it doesn't matter if it's depression or anxiety, I'm going to give the same medicine. Well, that's true now, but what about next year when they come out with a different medicine for anxiety? Also, it makes a huge difference what you do behaviorally and therapeutically with the patient. If someone doesn't have anxiety, why would you do exposure therapy with them for depression? So diagnosis is still important. Benzos are really bad in kids. I've done things where I'll use like give them like 4 pills for a month kind of thing if the kid is on a plane and they can't take a flight without a panic attack. But it's really I really reserve them because they're habit forming. So benzodiazepines hit GABA A, alcohol hits GABA A. Benzodiazepines are not that different from alcohol neurochemically. So would you give kid alcohol? If the answer to that is probably not, then you should be limiting benzodiazepines in kids. And in adults too.
Is there such thing, Sean, as anxiety rebound? I've heard that too with the benzos. So
you start to require more and more and develop a dependence, just like a tolerance, just like you would with alcohol. And then you could get a rebound in the sense that when you discontinue it, it's hard for your body to get back to baseline. But the really dangerous stuff is like sleepwalking. There's been like some unfortunate sleepwalking in cold leading to bad situations, or driving the car while sleeping kind of stuff. So because time is short, I'm just going to zip through the rest of this. And you can look all this up, you know. I thought more important was like how to have a conversation about the meds. But the most effective treatment, so a lot of you may be seeing clonidine, guanfacine for ADHD kids. You might see Strattera or Wellbutrin, but the most effective is still the stimulants. I oftentimes don't start with stimulants in little kids because you're more likely to get appetite suppression and insomnia in the little kids. So I usually start with something else, even though I know stimulants are the best choice in terms of effectiveness.
What age would you say little?
Like, I don't like to prescribe stimulants under 7 if I can avoid it.
Okay.
In kids who have something like fetal alcohol syndrome, sometimes their level of impulsivity can be so high that it's dangerous, where they don't even feel pain. So when it's getting to that level, or like they've been kicked out of 2 schools, going on their last, when it gets to that extreme is when I'll But I'll usually start with guanfacine, which is a lot more mellow.
As we move on, Sean just I think has a good point too. There's so much abuse of opioids, opiates, that benzos are particularly dangerous.
As are some ADHD meds can be used to make meth. So you have to be like, they're not too dissimilar from Sudafed, which can be used to make meth.
Right. Actually, and a lot of my kids, my non-ADHD kids, will be looking for Ritalin as like a street drug as well.
Right.
So it's interesting.
Yeah, and I mean, like they're basically the same compound. Like if you look for the generic of Adderall, it'll say methamphetamine when you prescribe it. But the potency between Adderall and meth is,
Right.
I mean, but if you took like 15 Adderalls, you could get, like, you know what I mean? You can have a similar kind of experience. So, so that's important. But Vyvanse is a good alternative for kids, and you can't get high on it. You can't snort it. You can't use it IV, and it has to go through your liver. So it can't go directly into your bloodstream and become active. It has to be processed and broken down by your liver.
Which one is this?
Vyvanse. So it goes up slowly and comes down slowly. If you're worried about abuse, that's the best one to use. But it's expensive. Some insurances don't cover it. So the one thing about ADHD, I think, is inattentive type is more common in girls, and that's the one that you usually would miss. But there's a lot of stuff that looks like ADHD, including kids who have intellect, right, learning disabilities. Autism can look like ADHD. Seizures can look like ADHD. What we would know now as disruptive mood dysregulation disorder, i.e. severe temper tantrums, can look like ADHD. It was really interesting. I had this little kid that 100% met the criteria is 5 for ADHD in the context of a really bad home life, and through play therapy over about 6 months, no longer met criteria.
I was going to say trauma.
So it was more of a reactive attachment. And the theory that we have there is that the kids are afraid they'll be traumatized, so they keep moving around their house. And if they're moving, they're like a moving target, sort of. And then so then they develop that as a habit pattern for interacting with adults. When they feel like they're safe with you, you see that they can sit. But it can take months for them to feel safe with you. Bipolar disorder is a huge one. So if you all were to say, what do you think the main difference is between bipolar and ADHD? Because this, like a lot of those kids I'm undiagnosing from bipolar look really similar to ADHD kids. Like both bipolar and ADHD kids will talk fast, will have impulsivity. There could be grandiosity even in ADHD. Poor personal boundaries. ADHD kids can say inappropriate things, even sexual things that you might think of with bipolar. So what's the main difference? Like one way that you can tell them apart.
Let's start with the big mood swing down, the polar opposite.
Right, exactly. So ADHD kids should look pretty much the same way every day. Right. And bipolar is cyclical. So you should see a week, several weeks, or months of looking like that, and then followed by a week, several weeks, or months of depression.
Alicia has a great comment. This slide is why I don't make the diagnosis of ADHD in my family medicine practice.
Well, it's more benign to diagnose a bipolar kid with ADHD than it is to diagnose an ADHD kid with bipolar. But it's all just about cyclicity. If the kid's that way every day, then they have ADHD. If it comes in huge cycles, then it could be bipolar.
It's tricky though, because sometimes, like, I just did an ADHD assessment on an adult, and I was supposed to make it like in an hour and a half, and just with no like childhood reports or anything. It's like, again, like Felicia's point, like how do you, and with a history of trauma, so
yeah, like
it's tricky.
With true mania, you should see someone not needing to sleep for like a week. And then so how do you tease that apart from a kid who has ADHD and plays video games all night? Eventually that kid with ADHD playing video games
crash
and drinking Monsters should crash.
Crash.
You know, and eventually, and the bipolar person wouldn't. They would just keep staying up every night and not needing to sleep and not feeling tired. So here are there are stimulants, there are non-stimulants. Most of the non-stimulants, the Tenex and the clonidine, Tenex is also guanfacine, work more through alpha-2 agonism. So that would be sort of slowing down your sympathetic nervous system is the best way I could put that. Whereas stimulants work on dopamine, so they're different mechanisms of action. And like we'd already talked about with stimulants, you really, with the little kids, get a sharp decrease in appetite and you get weight loss and the lack of growth. So you want to be careful with the really, really young kids. For those of you who prescribe, I would probably start a 4 or 5-year-old on guanfacine, maybe 1/4 milligram once or twice a day, which at that point, you cut the pill so many times, you just like have dust that you're giving them. But it's safer, you know, that way. And then maybe up to 1/2 milligram. And the main side effect for that is low blood pressure.
So, Sean, how do you think we just have a couple more minutes?
Yeah.
Just to let everyone know, I know we're getting to the hour, but for those of you who can't stick around, I think, you know, we'll be wrapping up in a couple minutes. I think this is great information for everyone.
I can consolidate the next few slides into a couple minutes, which is that I'm going to talk about both psychosis and bipolar, and both of them have the main point I'm going to make with these slides is that they're very heavy hitting, the medications. So you really want to make sure you have the diagnosis of psychosis or bipolar right, because the side effects are so significant. And if you can stick around, I'll go into which side effects. But if not, just know that any antipsychotic, pretty much, and any anticonvulsant used for bipolar or psychosis, it's going to come with a boatload of side effects. So if you need it, use it. But if you don't need it, don't use it. And psychosis, like 20%, up to 20, even up to 30% of kids at some point throughout their childhood will experience psychotic symptoms. Only 1% will go on to develop schizophrenia. So a lot of times psychosis is a normative process in kids with trauma when they're dealing with stress at home. And so it's common for them to sort of like see something out of the corner of their eyes, somebody passed away, grandma visits them. That's sort of normal. What's not normal is, you know, like voices saying, kill yourself, kill other people, them being influenced by those voices, seeing very clear, like demonic figures in front of them that are like not out of the corner of their eye, but like really there. Those are less common features. But even then, only 1%. So most psychosis in kids is not going to become schizophrenia, and a lot of it will go away with stabilization of psychosocial, sort of like stabilizing the family and the relationships and stuff like that. So yeah, I think the main point here, there's a lot of different antipsychotics, but so movement disorders can be permanent with antipsychotics, where like they never go away. And it could be like a tremor, it could be like facial grimaces. So
Never?
there are, so yeah, if you get tardive dyskinesia, some of it can be permanent. So you've got to be careful with that. And there's a whole spectrum. Some medicines are more likely to cause it, some less. Almost all of them cause weight gain. Some of them are a guarantee where the kid's going to really gain a lot of weight. Some of them are like 50% of kids gain weight. But even the quote unquote weight neutral ones, I've had kids come back with very low doses because I was mindful of that, 30 pounds, you know, in a month or something like that. So which leads to diabetes. Risperdal can cause gynecomastia in males, which is like formation of breast tissue, or it can cause lactation in girls. You can get cardiac side effects like heart arrhythmias, sedation, drooling. All of these medications lower the seizure threshold, so if a kid has seizures, it makes it more likely that they'll get them. The main point about bipolar is the episodic piece, and then we can just go on from there because of time. The rest of this could actually be pretty similar to ADHD. The depressive episode part is different too. This question is a sort of a specific question. If someone has rapid cycling bipolar, which means more than 4 manic episodes in a year, then the treatment of choice is Depakote. Otherwise, lithium is the best thing we have for bipolar. But so the ones on the top are seizure medications actually that work for bipolar. You can use antipsychotics, but look at these effects. I mean, we don't need to go into them. Kidneys failing, blood cell problems, thyroid problems, liver problems, pancreas problems. Depakote, I don't use in young girls because you can get polycystic ovarian syndrome, which can make, not only do you gain weight and get, you know, facial hair and stuff like that, but you also can have difficulty having a child. If Depakote's a double whammy because it kind of like chews up medications. So it slows your metabolism of other medications. So so you can get birth defects in kids, and then in Tegretol is the one that chews up your other meds. So what, for example, if a kid's taking birth control and they're taking Tegretol can actually make the birth control ineffective, and it causes birth defects in kids. So I mean, that's bad. If a kid needs to be on these, they need to be, but it's pretty rare. So that's about it, I think, for now. Let me go ahead and type my email into the chat box in case you guys have questions. You can just email me.
Yeah.
And feel free to ask questions now.
And thank you for everyone who was able to stick around for the end of this. As we can see, it's a very common, I think, topic that providers are interested in. So I appreciate everyone's great comments and questions. And again, Sean will be around and he'll have his email. If anything comes up, please feel free to reach out to him. And as you guys know, these slides are available for download for your references. And then lastly, we will send out the survey for everyone to fill out. And again, thank you guys so much, and we'll see you next week, same time, same place. Thank you. A lot of thank yous.
Yeah, thanks for sharing too.
Yeah.